WCEG Network. I'm William Bill Edwards, your host for Wisdom Wednesdays. June is Men's Health Month, and keeping with that theme, a couple of shows dealing with improving your health, we recognize the effects the whole family has in terms of good health. I am pleased to have as my special guest today a dear friend, Dr. Marcus Polk. Our conversation will center around the topic, the importance of good health. Good afternoon, Doc, or good evening.
Good evening, Bill.
Glad to have you on. We finally got you. Last couple of three shows I've had to deal around health and how people maintain good health. Two of your other friends was on ahead of you.
Gotcha.
So I know I had to get you. Dr. Polk, do me a favor. Tell us a little bit about yourself, who you are, where you've been. Yeah.
Absolutely. Well, first of all, let me just thank you, Bill, and commend you for what you're doing. Many times we suffer, Bill, not from lack of action, but just lack of knowledge. So this forum really creates the atmosphere and the medium, I think, to get good knowledge out. And we suffer a lot of times from just not being informed, man, making good informed decisions. So I commend you, congratulate you. Thank you so much for having me on. And I'm looking forward to this show. Just to get started, I'm a native man of Portland, Oregon. Before you even laugh and get the question, yes, there's Black folk in Portland. Was born and raised, spent 20 years, went off to Jackson State University at HBCU to play golf. That's how I got to Mississippi on the golf scholarship, and really enjoyed it, man. Best 4 years of my life. Went back home to Oregon Health Science afterwards, and then matriculated to Atlanta for a residency at Emory University in anesthesia, and have not skipped a moment, have enjoyed every moment of it, have not left since, and Atlanta is now my home, man. I haven't talked Southern now.
Yeah, listen, it's been great knowing you over the years and your enthusiasm to your craft. Tell us a little bit about your practice and what do you really do and how do you do it?
Absolutely. So I am Bill, I get the enjoyment of not only practicing one specialty, but I practice basically two specialties. I'm an anesthesiologist by trade. I did a residency. I'm board certified and fellowship trained in pediatric anesthesia. However, I was able to leverage that anesthesia to jump into another area specialty, which is interventional pain management. And that's basically dealing with, of course, with anesthesia. I'm sure you've had procedures, surgical procedures. You can't have surgery without anesthesia. And I don't care if it's just simple dental procedures, the dentist will give you Novocaine or one of the different local anesthetics to anesthetize you. So that's one form of anesthesia. Women have a different type of anesthesia when they have when they're in labor. They have a labor epidural, another form of anesthesia. When you must have some type of major surgery or invasive procedure, then general anesthesia comes into play. And so I'm an anesthesiologist, been practicing now since 1998 here in Atlanta. And it wasn't until 2000, roughly about 2002 or so, that I really start getting interested into interventional pain management. The group I joined down at in Riverdale, Georgia, we had a pain clinic. Of course, pain management was a little different back in the day. And the reason I'm sitting in this room here is because interventional pain management must be distinguished from pain management. It used to be thought that, you go to a pain management doctor and you're going to get medicine. You're going to get opioids. All right. And that was the main thought about pain management. Well, it's transitioned much to interventional approach, just like radiologists have transitioned from just simply reading x-rays to now performing uterine fibroid, taking away uterine fibroids and different, vein type vascular procedures. So we've shifted, and we do a lot of interventional procedures, man. It's easy for a physician or any doctor with a license, Bill, to prescribe you medication. Very few of us can take medication and put them specifically on specific pain generators that's causing your pain, whether it be your joints, whether it be a nerve that's compressed or irritated, right? Whether it be any other areas in your spine, your disc. We put that medicine over specific areas that's causing pain to try to speed up that recovery.
Let me go back to anesthesiology for a minute, Doc. I know that some people have been leery of anesthesiologists, and I understand from some of my doctors here. My doctors, Bennett and Collier.
Yes, sir. Yes, sir.
That sometimes they are finding a good anesthesiologist is hard to find sometimes. How safe is it? I mean, we've heard about the Michael Jackson situation and all of that. How safe is it today? And how comfortable should a patient be in terms of taking anesthesiology?
Extremely safe, Bill. The incidence of any type of death under anesthesia is like 1 in 30,000. And it's usually not due specifically to the anesthesia, but from underlying conditions. Okay. I always tell my patients, you have a chance of getting struck by lightning twice than dying on this table. Okay. The technology has improved over the years. I remember when I first started, end-tidal CO2 for simple sedation type procedures wasn't even in play. Okay. Now it's a requirement. Pulse oximetry, all of these different monitoring to monitor vital signs are now a huge part of the profession and has made it much safer to provide anesthesia to patients.
Mm-hmm. This whole concept surrounding pain management is that's amazing. Everybody has pain, and you go to your doctor, like my family doctor Collier, he'll maybe prescribe something for you. But you mentioned being specific as to where the pain is and not prescribing a whole lot of pills. Tell me a little bit more about that.
Absolutely. So when you think about pain, as you just stated, pain is a very subjective condition. And I'll tell you just as an overview that most people don't appreciate pain, Bill, until they experience it. Okay. And when someone else is complaining of pain, you just don't seem to have that empathy or really appreciate the devastating effects of how pain can have fallouts in other parts of your life, anxiety, depression, right? It's linked to suicide and all kind of other conditions because it creates stress, right? Heart disease, the whole 9 yards. So the way I explain pain is in two different categories. One is acute, meaning you have an injury or you twist an ankle on the basketball court. That's what we call acute pain. That's an injury that occurs that will most likely heal if you did nothing within 3 months. Okay. Chronic pain, by definition, is pain after a stimulus that occurs more than 3 months. And so in 2016, the CDC came out with guidelines that guided primary care physicians like yours that if you have patients who are experiencing chronic pain, and if they're in need of what we call opioid therapy, then it is recommended that you redirect those patients to a specific pain management physician who can get into what's causing the pain. Unfortunately, your primary care doctors, they don't have the time. They treat diabetes, they treat hypertension, they treat other medical related conditions. So getting into a pain conversation with you is probably not likely to occur. In fact, writing you medications is more likely to occur and getting you out of that office than explaining what your pain is all about. So that's where we come in to play at. Chronic pain physicians is usually people who have, the primary care doctor or the rheumatologist have already treated your arthritis or your some gouty type condition or some inflammatory condition, and you're still having a lot of pain. And that's when you come, they'll send you over to myself to be thoroughly evaluated for your pain condition.
Well, I'm a hypochondriac. You act like you got pain, and I get it. But let me ask you. I talked to Kanye about this also. It's a lot of things. You may have a pain. You may say a headache. So the first thing you do is they don't know about acute and all this stuff. They go to the drugstore and try to find some over-the-counter remedy that will help. And on the second part of that is, Doc, we got so many things on TV, on advertising, on television that cure everything. But then when you look at the symptoms of having it, it's worse than what you went in there for. So talk to us a little bit about that, because everybody thinks that they know how to cure pain by just going to the drugstore and getting something.
Yeah. So there's three different levels in taking on any type of pain related condition. The first level would be more of a conservative approach, Bill. That is, and it depends on what the etiology of your pain. Where is it coming from? Is it from an injury? Is it from a infectious type condition? So we really have to make sure we keep that in the back of our mind. But in general, most pain conditions, you try to rehab it first, right? The least invasive type of procedures and different methods, physical therapy, right? Chiropractic therapy, massage, right? Trying to rehab what we call soft tissues of the body, which are the muscles, ligaments, and tendons, which are all the structures that really support other major areas such as joints and the spinal column itself. So that's a biggie, okay? Then we toss in at that conservative level, Bill, things like non-steroidal anti-inflammatories. Remember, inflammation is probably the common denominator of most pain. And so trying to treat the inflammation of that area is critical if you're not on an anti-inflammatory. And I'm talking about the naproxens, the Motrins, the meloxicams, and things of that nature. These are non-controlled substances that are critical in the recipe to treating your pain. Then we get into other areas that, muscle relaxants and things of that nature that treat other areas. Then after that conservative approach, which is, using the physical therapies and the medications, opioids, non-opioid combinations, now you start coming to my level, and that's interventional, the interventional level. That's now taking medicine, Bill, and putting it directly via what we call percutaneous injections directly into the joint, right? Directly onto your lumbar nerve root that's being squished by one of your lumbar disc in your spine, okay? So that's that level. So we go through the conservative approach, we move up to an interventional approach. And then if you're not getting better, the next level, of course, is the surgical. Get a surgical evaluation to see if this is a more involved etiology and pathology that requires surgical care.
Well, Doc, I don't need to tell you, everybody, once you get to that level, everybody kind of fades out on you because they don't want no back surgery. And they'll tell you, even people who had back surgery will tell you, don't make that decision.
Right.
To have back surgery because it messes you up. So everybody's scared of that. How do you got a patient who needs to have that kind of a treatment? How do you relax them to the point where it's going to be all right?
Absolutely. So, I feel the same way. I tell patients as well, my job is try to prevent you from that next step, which is the surgical level. Unfortunately, most lumbar surgeries, if you just Google and look at the success rates, they're very small. Now, as an anesthesiologist, I can look at this from a different perspective because I've done the anesthesia for the laminectomies and the discectomies, and when they, maybe fuse a couple vertebrae together. And there's a little saying in the operating room when we see a lumbar surgery. There's no such thing as what we call a one banger, meaning you go in, you get fixed, and you're done. Okay, there's no such thing. We too see these patients come back repetitively for their second, sometime third event. Unfortunately, Bill, every time you go into that body, every time you go up underneath that skin with a knife, you leave behind scar tissue. Okay, that's just what the body does to try to heal itself. And unfortunately, that scar tissue starts pushing up against nerve endings and sometimes nerves and other structures that will even enhance the pain more. So probably the most common condition I see and I get referred is lumbar back pain as a result of a patient who has had previous surgery.
So now the other question I've asked of the other two, and that is, I mean, it's just like me. To get to you, Collier would have to recommend him, say, go see Polk. All right. So at what time in his treatment does Collier, I'm just using Collier, doc, don't get me, you're my doctor, you're all right with me. Yeah. But he'll say, well, I've given you all the medication. It's time to go see Marcus. So
Absolutely.
at what time does that occur? It gets that critical.
Yeah. So, and I thank Dr. Collier, him, his partner. I'm up the street here in Hiram right now,
Right.
and down on Thornton Road. They've sent me patients before. They are one of our referral sources. And so, if you're listening, Doc, thank you so much for all your support. But it gets to a point for a family practitioner or any other doctor who's not pain management to use their judgment, first of all, on if whatever you're doing is causing any improvement for the patient, right?
Mm-hmm.
If nothing's happening at your level and you need another pair of eyes more specialized into pain management, then that might be one indication to send. However, in 2016, Bill, the CDC released some guidelines that guided people like Dr. Collier on
Mm-hmm.
when to send to pain management.
Mm-hmm.
And the guideline says if you are prescribing over 50 morphine milliequivalents of opioid medications, then they recommend that that patient go to pain management. And they need to go there not only to get to the underlying cause of their pain, but if you're prescribing those type of potent medication, these patients need to be monitored, Bill. They need to be monitored to make sure that those drugs are not being diverted, that those drugs are not being abused, right? And that little Johnny or the son or daughter don't get into these medications and cause bad outcomes. And so, of course, this was in the middle 2016 of the huge opioid crises. We're still in a crisis, but they did speak up and guide primary care physicians and other physicians on when to send to us.
I'm not taking for granted that people know everything, Dr. Polk, but talk to us about this opioid situation. What actually is that, and what kind of problems has it been, bestowing upon us?
Yeah. So, opioid medications are medications that are controlled substances. There are different classifications. We can go from the DEA has classified these medications into schedules. Schedule 1, Schedule 2, Schedule 3, Schedule 4. And so these are medications which carry what we call an abuse potential. Okay. An addiction potential. And so, there's many factors to describe this whole opioid crisis. Of course, there were patient factors, mental health and addiction issues that played a role. But we can't leave out Big Pharma, who played a huge role, right, in pushing these medications that they were okay to take. They improved quality of life and left out the addiction part, okay, back in the day.
Mm-hmm.
And we can't forget our government, who also played a role, as Dr. Calder would tell you, at pressuring us as physicians to respect pain. But I think it was, in the time of this big pharma input, it was overemphasized to the point that if you did not ask a patient in the emergency room what their pain score was, then you could be docked money and other, things in terms of not assessing what pain scales became what we call the fifth vital sign, and it was critical to do so. So all of it together led and tied in to lead to the opioid crises, and we have it today. Now, let me tell you kind of the statistics. It turns out that in terms of all opioids written in the United States, that interventional pain management doctors write only about 5% of those medications. Most of these medications come from your primary care doctor. Okay. They are probably the largest prescribers of opioids amongst all specialties. Next might be ER doctors. And then after that are dentists. Whoa. That prescribes most of your opioids. Yeah. That's great. So you can see, really, they don't get to us really until they're already on 4 Percocets. They're on 3 Perc. And so the challenge I have day in and day out, Bill, is assessing motives. I play chess day in and day out on really where are we at in this process? Are you opioid naive? Are you, are you familiar, your body familiar with it? Because no one ever have walked into my office asking to be addicted, or any doctor's office asking to be addicted, right? There's properties of the drug. There's properties on how your body metabolizes a drug that all factors into, the 4 different stages of leading to addiction. Okay. So, but I hope that answered your question, man. Just cut me off anytime you need to.
No, we hear this. You made a point. No one comes in asking for addiction. However, when you're in pain, you want relief. And I understand, from your comments that there's pain, the cure for pain, and then there's the management of pain. I'm not sure in a lot of cases the cure for pain actually comes into existence. Maybe you could shed a little light on that.
Yeah. So my approach, and our approach here at Georgia Pain and Spine Solutions, Bill, is, I tell patients on my new patient evaluations, my goal is not necessarily to bring your pain score from an 8 down to a 4 or a 3. My goal, Bill, is to bring your function up from a 4 to an 8. Okay. Bill, I can give you enough medications that will snow you, man, and you wouldn't have a worry on this earth about pain. Right? But what does it matter, man, if you can't go and hold your grandbaby?
Right.
What does it matter, Bill, if you can't go out to the mailbox? Right? So function is something that we forget. And as physicians, we have to kind of compromise those two and get patients right in that sweet spot. And first of all, get them to understand specifically if it's chronic pain that's lasted more than 3 months, and probably pain that they'll have to deal with over the course of the rest of their life, right? It's about management. It's not about relief, totally.
Well, you got a question. Dolores is going to give it to you.
I have a question that's coming on Facebook. What is your view on society's belief that African Americans can tolerate more pain than other races?
Okay. Well, I think what we're really talking about is some of the myths of not only pain management. There was a time where it was believed that we as Black folk had a higher tolerance, and hence is what gave slavery the green light to continue in its path, right? There was a point in time where they used to take women and do sterilization procedures on them without any anesthesia. Black women, I should say, right? Because of that belief, right? And we can go on and on. What we're really talking about, though, is how we have gotten from a culture of not really trusting healthcare and what it has to offer because of this very dark path of where we've been. Tuskegee, right? Experiment. Yeah. Absolutely. And so when the COVID pandemic came about, you had a lot of folk very hesitant for those very reasons. Okay. So I think it's a valid it's a valid thought based off of where we've been. But the reality is the human body, my blood cells are the same as anybody else's blood cells. You know, there's no difference of structures, the nerve endings, there's no difference whatsoever. That's the reality.
Mm-hmm.
Okay, I have one more. What determines when the pain med pump or dispenser is used?
Say that again.
What determines when the pain med pump or dispenser is used?
Pain med pump. Okay. So now what we're talking about really is when we get into when a patient is hospitalized and you're trying to treat pain after a surgical procedure, some type of medical related pain that the patient is experiencing in the hospital. There's what we call a PCA pump. All right. And that's just basically, instead of me having to come up every 3 hours to the ward and ask the nurse to write, 5 more milligrams of morphine for this patient, I can go and program a pump that gives that patient so much medicine every hour. They can hit the button as much as they want, but there's a limit lockout on it, meaning they can't get enough. They can't get too much because I can put all the parameters on there. And so that's what we call a PCA pump. It's just one of those tools we use in pain management, mainly acute pain management, when you've been hospitalized or in that type of setting where you might have access to a pain pump.
I know I want to ask you that you're being in pain. I would anticipate that a lot of your patients are like elderly. What is your patient mix? I mean, I'm sure that pain is no respect of age. What's kind of like your patient mix?
Yeah, so that's a great question. I would say the sweet spot is anywhere about 40 to 85. But sure, I would say probably 50% of my patients are over the age of 60, right? And you would expect that. I mean, the body, things start happening. It's just like a car at 100,000 miles, things start happening. The joints wear out. There's a such thing, especially in your major joints, your hips, your knees, your ankles, right? Though that type of arthritis is a different type of arthritis. We're talking about wear and tear arthritis versus the type of arthritis you generally get, inflammatory arthritis you get in those hands and those fingers. That's rheumatoid in general arthritis. So there's a different type. So the more you're driving the car, right? The tires wear out sooner. Well, the more you're upright on the body, sure, those wear and tear joints wear out as well as other parts of the body. So that's where a lot more of the pain comes in. And then I would add that the body is less, the body don't recover as quick, right? As we get older. One of the things that we notice, recovery time is a lot longer than what it was when we were 25 and 30.
Kind of figured that would be an issue of how old you were. But let me ask this, Doc. Yeah. And I talked to the other two doctors about this too. I'm gonna get off the medical part for a minute. There is a lack of in our communities the ability for us to get to a hospital, things of that nature. Our ambulance services are really weak. There's nothing past I-20 in terms of an actual hospital. I had I had an incident the other day where my ex-wife had a kind of scare about her heart and wind up driving herself to Douglasville to Wellstar. I didn't know what Wellstar was, right? Until I went to see her, and I was like, "Oh my God, this is pathetic." Doc, what do we? And I know we're gonna talk about this. What do you call it? This the certificate of need and all this kind of stuff. But Doc, people are dying, Dr. Polk, all right, because they can get those services you provide, in the areas in which they live. Talk to me a little bit about that and how you feel about it.
Yeah, I mean that problem is not isolated, of course, to Atlanta. That's a nationwide problem, and the underserved areas have always suffered. They've gotten the short end of the stick in terms of resources, and sometimes they even get the rug pulled totally from underneath. South Atlanta hospital, Midtown Atlanta, Atlanta Medical, and Cleveland Road. I'm forgetting the name of the hospital.
That was South Fulton Hospital.
South Fulton, absolutely. Well
Right.
stocked. So, I think it really, though, speaks to a bigger issue, Bill, and that is when these big corporations take over these areas, they only took South Fulton probably to add into that underlying profile of coverage. But were they committed to changing lives in South Fulton? That becomes the issue. And I don't think so, based off of the resources and disproportionate resources that you saw up here in Paulding, Kennesaw, versus your South Fulton and Atlanta Medical Center. You can palpate the difference of resources when you walk into these facilities. And so, when you don't have patients, or you have a lot of underinsured patients, it's a trickle-down effect. It's tough to get physicians now because now, of course, they need to eat, right? And get paid. And so it's a huge, huge fallout from the top. And that is, putting the right resources in those right areas to get adequate health care.
Yeah, and that's important. I mean, I've heard the underinsured and things of that nature, but it's heartbreaking to know, that the lack of medical attention that we have in these African American communities. And hopefully you'll be able to come over here in a couple of years and open up an office. Hint, hint, hint.
Well, I have Riverdale, 195 Upper Riverdale Road, Georgia Pain and Spine Solutions. We have 3006 Claremont Road, Georgia Pain and Spine Solutions. And of course, I'm in my Hiram office right now. So we've gotten close to South Fulton. But yeah, I agree that definitely. The thing about also understand this, Bill, that when you talk about specialties, right? Well, we get our patients from people like Dr. Collier, right? So primary care doctors. We get our patients from neurosurgeons, orthopedic doctors, referring their patients into us after, those criteria that I mentioned earlier are breached. So it's hard for me as a specialty to go into an area where there's no referral sources.
I got you.
So
makes sense.
Yeah, that's the fallout again. Yeah.
So your relationship with family doctors, I think, is most important. Let's say, for example, I come to you and Collier and you have to have a relationship back and forth. You're sharing the same patient. How often do you talk to that family doctor, as opposed to what you're doing and opposed to what he's doing?
Oh man, that's a great question. So in medicine, like you said, you've had a primary care doctor, you've had a urologist, myself, interventional pain management doctor, anesthesiologist. Bill, all of that plays into how important the coordination of care is to any and every patient because they have a host of issues and medical problems that we all must manage, right? So we're talking about coordination of care. And that requires a good relationship. It starts off with, yes, I've been to Collier's office. I've taken lunch to Collier's office initially when I moved into the area, and subsequently, to make sure that I establish a good relationship, that they know who I am, what we do at Georgia Pain and Spine Solutions to complement what they do.
Right.
And so it's very important to take on that attitude initially because that's what you're doing. You're building a practice. And you can't do that in private practice without these type of critical relationships. It don't work. It won't work. You must.
So realistically, a person could wind up with a string of doctors in terms of their care. And hopefully those, if you wind up with 4 or 5 doctors, you would hope that they would be communicating with each other as to what you need.
Absolutely. Now, what's nice now is these electronic medical records, Bill, where, I can go on. If he's a part of, say, the WellStar system, everything feeds right into my system.
Okay.
Right? So the improvement of technology has made it much easier to communicate, without physically, going down to see him or getting on the phone. But yeah, I think, maintaining that relationship is critical. It's critical to the viability of my practice, number one, but also taking care of these patients because you're right. We have patients who will go back to their primary care office and not tell them that I just prescribed them a certain medication, right? So now you're getting duplication of care. You're getting duplicate care. And so we have a lot of systems in place to prevent that. I want to say probably almost maybe 8 years ago, the state came up with their prescription monitoring program that allows any physician to go in and look at a patient's prescribing history. I can see if Dr. Collier has prescribed any opioid type medications, right, or scheduled medications, I should say, and be very clear what this patient is with Dr. Collier. But just to answer your question, yes, we do communicate in various ways, and technology has made it much easier now for us to do so.
Well, technology has always done that. Right now, I know a lot of doctors, I don't know if you use it, but they use the telemed procedure. I mean, you go in and you get your physical, and then your doctor calls you on the computer, and just like you and I talking now, we're talking telemed. I think that's great.
It was a game changer. It was a game changer, Bill, specifically during COVID. And to give you an idea of that, it used to take me probably, I would see probably 4 to 5 patients in an hour, on follow-up patients. Right. Telemed, just by nature of the visit, right, allowed me to see more patients than that in an hour. So productivity improved just from telemed alone. Okay. Now you can't see an infinite number, obviously, of patient. There's some limits to it. But if, it allows me to see some patients might just have a question. Right. They just need access. They just need a quick ear on an issue that they're having. Telemed is great for that. They don't have to come into the hospital. If they have access to their physicians via telemed, that's a great thing.
How long in this whole concept of pain management? It's hard for you to say, but when I look at pain management, think about it. It's a long period of time. When do you stop? Go to the next level, because pain can be consistently on. Is there any stopping point, Doc, in terms of your management?
It depends on the pathology. It depends on the patient and what the condition is. Again, if you've had lumbar surgery 2 or 3 times, most likely you're going to deal with pain for the rest of your life, Bill. If you end up, in, if you end up in my clinic, you've been sent here because another physician can't manage your pain, and therefore he's sending you into my clinic. Now, there's various ways, again, how we do that. We manage it with medications, opioid and non-opioid, with therapy. We manage it with injection therapy procedures. And so we use a comprehensive approach, again, to maximize pain control, but also to improve function. Function is the key. Function is the key.
And in your younger patients, that 40-year-old and lower beyond that, what is usually the most persistent complaint in that age range?
Absolutely. So probably the most, again, the most common complaint in my center is any type of spine related pain, whether it's the neck, the mid back, or the low back. Okay. And so even the younger ones come in with that. We do get occasional joint patients that we can manage here, meaning we see a simple issue going on in the joint via some type of imaging, and we're able to do injections, and they do well. They get better, right? We speed up the process by putting not only a local anesthetic into that area, but also a steroid, which is the most potent anti-inflammatory that I can give a patient, right? And so we kind of speed up that process. So, not in all patients, coming to a chronic pain management, it might be short-lived, if we get them better. And a lot of times that's just communication, man, talking to your patient, understanding where they're at, what the goal is here, and kind of working the angles and tailoring their treatment plan to them.
And unlike my medical doctor, I mean, you're talking about pain once again. Your revisiting schedule probably is a little bit more often than the regular doctor, right?
Absolutely. Specifically, by law, specifically if you're using any type of opioid to treat the patient's pain. So again, that monitoring piece comes into play, right? Because if you leave out the office and you're involved in some motor vehicle accident and somebody dies at the scene, whether it's in your car or or the other's car, and you got a prescription bottle laying on your seat, they're going to beeline it right back to my office because number one, did this mind-altering substance cause the accident? Right? So there's an investigation that needs to take place. You saw it with Michael Jackson. Within 2 days, the first thing came was who the docs were that was giving him the medication, right? You saw it with Prince within a day or so. What doc prescribed him X, Y, and Z? All right. So, we call it the power of the pen. Once you write that script, okay, you're responsible. And that's why interventional pain management has become so delicate. And most physicians like Dr. Collier don't want no part of it. They don't want to deal with and jump into that piece, that side of it that can get real kind of dicey. If a patient is becoming addicted to these medication, assessing addiction, triaging them to somewhere that they can get help if you see those signs of addiction, right? And so, absolutely, man, this is really a delicate subject.
I'm always intrigued even when you go in hospitals and doctors come and say, "What's your pain level from 1 to 10?" I mean, how accurate do you think a person is going to give you? They're probably going to go over.
Right.
If you use that technique, how accurate do you think that's going to be?
So again, that is one of the self-reporting tools that's used. There's Ultra scores that we use for kids. Instead of the numeric, they have faces that they can point to.
Yeah, I saw that too.
Yeah. So these are just different objective ways to assess a patient's pain levels. But as I stated earlier, it's such a subjective condition, right? You really don't know. And that's why it's critical for someone who is competent and well qualified to evaluate this patient, right? Because you have to get through that subjective piece to get to what's really the issue here. And you do that, Bill, by a thorough, history, talking to the patient first, because you'll get so much just in that history. All right. Then you put your hands on the patient, right? You can touch an area of the body or do some type of manipulation that we get a sense of if it's over exaggerated or not. All right. And so, then we get other types of objective data, and those are the imaging, the x-rays, the MRIs, the nerve conduction studies, and other types of blood tests that might guide us in the diagnosis and exactly what's happening with the patient. So, giving me a pain score of 10 is not enough evidence or what we call medical necessity to write you a script of 10 milligram Percocets. Yeah, this is not that office. Okay. But unfortunately, there are centers, not necessarily interventional pain centers, but there are centers that does it all the time. And you read about those physicians, getting their license dealt with or going to jail.
Let's talk about health medications. We get some people say, go down to the drugstore or the health store and get XYZ and drink that and you'll be all right. Tell us a little bit about health. Is that adequate to say that health medication from health stores are helpful to a patient? I want to put you on the spot, but
what type? Are you talking about herbal meds and
herbal meds, stuff of that nature?
Gotcha. Okay, so you're more a naturalistic approach.
Yes, more naturalistic.
Oh, absolutely, Bill. Absolutely, man. I'm a big proponent of natural medicine if it works for you. As long as there are no contraindications to what I'm prescribing you for a legitimate cause, right? Then it makes you feel good to take a herbal tea in the morning or take some fenugreek in time, then I'm all for it. I'm all for the naturalistic side of complementing what we do, in westernized medicine. Absolutely.
So, you always getting to the point where, you're one of the final doctors, I got pain. My question would be, if a patient came to you and said, Doc, I got this, how did I get there? And we're going to the preventive side of things now. And I look at you as more the medical side, the healing side, but Doc, how did I get there?
Well, it's very interesting. So let me first give you a personal testimony. Bill, I stopped eating meat, man, about 4 months ago. I can't tell you, brother, how good I feel, man. I can't tell you from a digestive standpoint, from a weight standpoint, from just a mental standpoint, man, it's been a real treat. I wish I'd done it a long time ago. Still do a little fish, do some shrimp every now and then, scallops, but probably 3 days out the week, man, we're totally veggies. Okay, probably maybe 2 or 3 days, then we'll have some form of meat. So I think eating right, proper diet, can cure a lot of things. A great person who's a big advocate of this, which changed his life, is Eric Adams, the mayor of New York. He tells a story of going to a vegan diet and not having to take any more diabetic medications, right? Weight is the next thing, right? When it comes to pain, you could probably take 10-15% of or reduce that pain scale down by losing 10 to 15 pounds, right? 20 pounds. There is a correlation between the two, because just think about it, man. If the body of those joints is not carrying as much, then they're not going to wear out as quick, unless you're doing things that just is not favorable to those joints, right?
Yeah.
So it's the simple things, man. It's a simple prevention. It's all of those simple things, right? that gives you a lot of mileage on the back end.
Well, underweight would be the same thing, wouldn't it?
The what now?
If you were severely underweight, that would have the same purpose, wouldn't it?
Underweight can have its own issues too. So malnutrition, yeah, it can have its issues as well. But you know, the fallout of overweight is an entirely different fallout than being underweight. Okay. Because there's so many other you know, comorbid conditions that can take place by being overweight. You talk about diabetes, hypertension, and then, you know, some of the sequela from those conditions, high blood pressure, the whole nine. But certainly, yes, underweight can have its issues as well.
Well, and how long have you been doing the pain part about it? I know you were an anesthesiologist and you kind of warped it into this pain procedure. You still do any anesthesia?
Yeah, I do. Yeah, I do. You know, for the sake of this talk, I didn't want to get into some of the other business ventures, but you know, Bill, I actually own 4 dental facilities as well. And what they are sedation centers for pediatric dental center. I think you heard me talk about it, and some of the folks I introduced at my Christmas party with that respective company. So, but today I still practice. We do Anesthesia Consultants of Georgia, which is another company I own. We have 2 docs who was also at the party, and about 3 CRNAs now. At one point in 2016, Bill, I had 7 docs and about 15 CRNAs. We had over 35 centers, ambulatory and office-based centers, all across the city that we would triage to provide exclusive anesthesia services. So James Bennett being one of those. I don't know if you know or not, if he told you, but Axis Anesthesia back in the day when I was a young pup, that's when I got exposed to ambulatory anesthesia and going and doing anesthesia outside of the hospital.
Okay.
One of those first offices happened to be Janelle Foote and James Bennett's office.
Okay. All right.
Absolutely, absolutely.
Well,
that surgery center is no longer there now. I think the cancer center, Emory's Cancer Center now took over that space down there. But I'm sure James made a lot of money on that site.
You know, Bennett, he got everything in there for you, boy. He ain't gonna let that here treat you as you come. But I just it's amazing, you know. I guess some of the viewers here wouldn't even realize the fact that a person like you exists in terms of pain and wellness, and that they could actually go into a person like you and get medications or whatever they need to do to make them whole again. So that's very important for them to know. Well, you know, you got all these offices and stuff. You know, you've been holding back on me. I don't know I don't know too much about you anymore.
Yeah, we tried to give you a little sneak peek, man. When I invited you to my Christmas party, that was a party that we do every year about that time, a holiday party that involves all 3 companies.
Yeah, I did see
anesthesia company.
That was a taste. That was a taste for me.
Yeah. You got a chance to meet some of my anesthesia staff and some of the providers there. You saw the pain side. And then we had the dental side. I brought up a few of the young ladies who have worked on the dental side. One of them, I thought she wanted to become a anesthesiologist. Man, we started exposing her to the dental side, and she changed on me. Bill, she wanted to become a dentist, and so she's doing her 2nd year now at MCG. Their dental school. She got in, and we put quite a few into medical and dental school. One most recent is your frat brother, Evan Fleming, Dana.
Right.
Son.
Right.
Yeah.
Well, you know, I just want to let everybody know that you're a capo, but we won't hold it against you.
Yeah. You let them know. Say it again.
I ain't said
Say it again.
You heard me to say it that time, but you've been great, Doc. And you know, just briefly before we leave, there's a lot of conversation about the lack of doctors, and especially African American doctors, you know, in the medical field. Is there a sense of urgency? And I know you're doing your part to get people in school and get them educated. Is the urgency as deep as it seems in terms of getting and hiring medical professionals?
Oh, absolutely. Particularly black doctors.
Mhm.
Absolutely, man. I think here in Atlanta, we get a kind of a false sense of need because Atlanta is Atlanta, and it's just a lot of black doctors here.
Mhm.
But you go outside of Atlanta, man, and you go to Detroit, you go to Portland, you go to California, just different areas, and you don't see a lot of us in
Mhm.
medicine. Okay,
Mhm.
far and few in between. So there is an urgency because part of of knocking down those myths that we have as black folk about healthcare is putting someone in front of you who looks like you that you
Mhm.
can share these things with, right?
Mhm.
So it is absolutely critical in the overall armor of dealing with healthcare and improving healthcare,
Well,
particularly for
Doc, well, Doc, you continue to do what you're doing. I'm proud to call you a friend. You're answering the call to the community, and not just in terms of making money and doing what you do, but trying to educate people who you've been around to take them to the next level to give care to individuals. So I appreciate that with you. And even though you went to Jackson State, there's a few people that come out of Jackson State that do a few things. But Doc, I really appreciate you. This has been very informative. And I was like I tell people, I got three good ones. I got Bennett, Collier, and Polk.
there you go.
Maybe I have for another 300 years.
Hey, we appreciate you, Bill. I
Yeah,
thank you so much, man. I'm humbled by the invitation, brother.
yeah.
And hopefully your audience learned something.
Okay, I know they did. Thank you so much, Doc. I appreciate you.
Thank you
We're
now.
we're the Worldwide Community Entertainment Group, where we speak life into the community. You can join us on Apple TV, WCEG TV Network, Roku, LinkedIn, and Smart TV. The topics that we are presenting here are those of the host and guests, and not WCEG Network. Thank you for your support. I hope that you enjoyed this session with Dr. Polk. And as always, I always tell you, in all you're getting, please get an understanding. Thank you all so much.